And I said, has a dietitian seen her yet? Because she's lost a lot of weight. Because she'd actually lost weight before she started her chemotherapy. And the doctor said, Faith, I know you think that nutrition is important, but it's not going to change the outcome. I said, it's not going to change the outcome. I know she's going to die. I'm not going to try and say anything different than that. But the outcome may be different in her quality of life and how she feels and what she can do. And so I think those are the kinds of things, even though the gold standard of oncologists have to do with survival, whether we're talking about cancer patients or patients with lung disease or HIV, it's really what people can do with their life. Regardless of how long that life is, it's the quality that makes the difference. The interesting thing is my dad outlived my mom for about 25 years. And he had COPD disease, chronic obstructive pulmonary disease. The last 3 years of his life, he was completely dependent on oxygen. But he still worked as a deacon in the church. He gave communion every week with the priest. He mowed the lawn to make it shorter. He used that. He did all sorts of things that still, again, was his quality of life. And a lot of that was the importance that his new wife, my stepmother, believed in nutrition, and then also when they talked to me about it. So again, it's the nutrition, it's the exercise, it's being active that makes a difference. Now, one thing I don't have, that must be this one, to go forward. So how many people in your lives have gone through a disease where they've lost weight, have lost part of it? Let's see that show hands. And my guess is that also makes you passionate about this. It really makes a difference in terms of what we bring to the table, not just what the disease or the patient brings to the table. Now, on your first impression here, and my guess is in your clinic or in your doctor's clinic, patients like these will walk in. So in your first impression, 1, 2, or 3, who is the best nourished? I know it's early. Just throw out a number that you think is right. I won't know if you're right or wrong. I can't see you. So who says number 1 is the best nourished? No? Okay. The one in the middle, is she the best nourished? I see heads like this. No? Number 3. Some people going, maybe. Okay? So who is the worst nourished? 1? Okay. I hear a few 2s. Show of hands. Number 2? Okay. And number 1. Okay. Well, this is going to show you the strength of the the strength of the PG-SGA. The higher the score, the higher the risk or the nutritional deficit. And as you look at number 1 and number 3, they have exactly the same score. And the lower the number, the lower the risk, the better nourished. And that's number 2, which most of you said, or a number of you said, was the worst nourished. So when people come into your office, what we look like doesn't always represent what's really going on in the patient. And by the PG-SGA, and I think a number of you have seen the PG-SGA before, and one of the strengths of it is the point scores that go from 0 to 39 if you do the full, and for the 4 boxes, 0 to 36. And basically that short form would say that these patients who fill this out themselves are giving you the most information, and the triage, anything above a score, at or above a score of 9, indicates critical need for nutritional intervention. So this person's already getting it, and we're going to talk about this so you can see how we got to those numbers and not just taking my word for it. Now, the objectives of this session, which I think is very exciting that we have so many people. In fact, my understanding is there were more people than you who wanted to get in, so you're very lucky. But the objectives at the end of this session are that each of you should be able to describe the historical basis for the development of the PG-SGA, to explain and understand the rationale and the basis for how we score the things, why we score them the way we do, and why we included some of the components as part of the score. We're actually going to have you demonstrate in a case-based scoring those 3 patients so that you can figure out exactly why those patients are scored the way they are. And I think probably the most important one is the last one. I want every one of you to think, at the end of today, what can I take back to my patients, to my clinical practice, that's going to make a difference? Because I can talk about all sorts of science, I can have lots of pretty graphs, but if it's totally useless to you, there's no reason why you should be here. So I'm hoping that each and every one of you will be able to do something that makes your patients or your clinic a better place. Now, one of the things that I came up with, and I wish it were not always true, but the reality is nutrition is not very sexy. Sometimes people don't get excited about nutrition. And lots of times doctors don't get excited about nutrition. One of the strengths that I have, one of the great things is I'm a physician who has multiple degrees, and if you're a physician and I'm talking to you, you're going to listen to me sometimes in a different way than you might be listening to a nurse or a dietitian or a nutritionist. Not fair, but that's the reality. And one of the things is I realized is that we all know what immune competence is. That's the immune system working in the best way to do it. So that's more like a scientific term. So what I thought is, how do we take nutrition and put it more in a medical model? And I came up with the concept of anabolic competence. And that's to say that anabolic competence is the state that optimally supports protein synthesis and lean body mass, as well as the global aspects of muscle and organ function, immune competence, and quality of life. And it's this integrated approach that really is much more than just nutrition. But what it says is we need to take care of the hormonal makeup or the hormonal milieu of the person. We have to include an anabolic stimulus of exercise. We want to maintain the hormonal milieu. If someone is low testosterone, they're not going to make muscle as well. If they're hyperthyroid or hypothyroid, they're going to have a different effect in terms of the nutrients that we give them. So really understanding what's happening to all 3 of these is important. So it's combining these 3 aspects that really optimizes body composition and physiologic function. And so when you're talking about that concept of anabolic competence, all of a sudden it takes a different meaning, and it also is much more likely to be successful. One of the things that we'll talk about with the PG-SGA is if you are the best dietitian or nutritionist around and give great counseling and work with your patients well, and they have uncontrolled symptoms of nausea, vomiting, constipation, diarrhea, all the counseling is really for naught. It doesn't make a difference until you get those symptoms under control. So it's really an interdisciplinary approach that's going to make this work. Now, one of the things that I think is important is a lot of times we wait too late. And as I've talked over the years to physicians, lots of times they'll say, well, once somebody's lost 30 pounds or 10%, those are my magic numbers that will push me to intervene. And I am I have a smart mouth sometimes, and I'll say, does that mean that all of your patients who've lost 10% started out at 300 pounds? Because 10%, 30 pounds, that's 300 pounds. So the reality is there's a disconnect with what people think they're doing and what they really need to do. And this first table was done by George Blackburn and was published in the Journal of Parenteral and Enteral Nutrition in 1977 in an article that was known as The Skeleton in the Closet. And it talked about the dirty secret that we had in medicine, that there were a lot of malnourished patients, and that it was having not only the skeleton because they were thin, but the skeleton because it was a bad secret. And what he found and what they reported was that the impact on outcomes was the same whether someone had lost more than 10% in 6 months, more than 7.5% in 3 months, more than 5% in 1 month, or more than 2% in 1 week. So it's more how rapidly the weight loss occurs that makes the difference in terms of its physiologic impact. And as we talk about the PG-SGA, we'll also talk about the weight loss over 6 months, over 1 month, and over the previous 2 weeks. So that will, again, put us back to knowing where we are in terms of those components. Now, there's a thing called the common toxicity criterion. It's used by the World Health Organization. It's used by a number of the oncology groups. And what it does is it takes basically scoring of all signs and symptoms, pretty much from 0 to 4, except for 5, which is death. Not one of the toxicities that we ever want to think about. It's interesting, these toxicities are only while they're getting treatment. So if I have a lung cancer and I walk into my doctor's office and I've already lost 5% of my baseline weight, I don't get any credit for that. We start out again at 0 and only address what I've lost when I've been on treatment. So if we know that someone who loses up to 4.9% or 4.99% of their weight, in the mind of the oncologist, that's no toxicity in terms of weight. Up to 10% is only a mild. So 1 is mild, moderate, severe, and life-threatening. Life-threatening is not even defined, and a patient, regardless of how much weight loss they had to begin with, has to lose up to 20% or more to be considered severe weight loss. Clearly, we're waiting too long, especially since that only accounts for what they've lost on treatment, not the 10% or the 20% that they lost before they came in. So these numbers are important to know when we think about why sometimes nutrition may not be as successful. When I talk to oncologists who are saying, well, Faith, you know, the thing that's going to make a difference in my patient living or dying with their cancer is whether their chemotherapy or their surgery or their radiation works. And I'll say, that's clearly an important component of it. But you want to have the people diagnosed and sent to you early so that you're more successful. But why do you wait until to send them to me until they have stage 4 malnutrition? Just like you want a stage 1 cancer, I want a stage 1 malnutrition, or know the risk factor up above. And so I think that's important. Now, we tend to think of lean tissue predominantly as skeletal muscle, and all the things that are listed here: fatigue, activity, bed rest, blood clots, pulmonary emboli or clots to the lungs, risk for decubitus or bed sores, increased risk for pneumonia. Those are all things we tend to think of in terms of skeletal muscle. But there's also smooth muscle that's also impacted. A lot of your patients may have an okay appetite in the morning, but after they've had breakfast, they just say, I'm not hungry the rest of the day. Well, we know that about 2/3 of people who have advanced disease and weight loss have decreased gastric emptying. So something as simple as having them getting up and walking after breakfast so they can use gravity to actually increase their gastric emptying is something that's a very simple thing, and again, it gets that exercise in, but it also makes it so their appetite, their early satiety may be improved. How many of the patients that you talk to have problems with constipation? Very common. What's interesting is we don't tend to think of the muscle of the intestine, whether it's the large intestine or the small intestine, as muscle that has an impact. So part of the constipation may well be the pain medication, but it also may be part of the loss of the lean tissue that's part of the intestinal wall. Also, a lot of times patients, if they're not very active, but they've also lost a lot of weight, just standing up will get lightheaded. And we tend to think of it's their volume or the fact that they've been inactive. But again, the lean tissue inside the vasculature can make it so it's not as responsive to changes in position. And finally, there are other components in terms of visceral protein status, antibodies, enzymes, etc., that can make a difference. So it's a lot more than just whether I look at their legs and see that there's atrophy or that they've lost muscle, but it's the totality of things. I think one of the really exciting articles, and there are now approximately 170 articles, and I think you actually have a number of these in the bibliography, that have been published utilizing the PG-SGA. And this is an article that came out last summer out of Brazil. We find that actually between Portugal and Brazil, there's a tremendous amount of interest in terms of nutritional assessments and also the validation. We're doing one with the group in Portugal, in Brazil. What's interesting is they actually looked at gynecologic cancer patients and found that not only was there an increased length of stay in the hospital for people who had, based on the PG-SGA, if they were well nourished, their length of stay was shorter. If they were moderate or suspected of malnutrition or severely malnourished, they had a longer length of stay. But I think the exciting part is, remember, scores that are greater than or equal to 9 points address critical need for intervention. What they found was that people who had a score above the cutoff that they looked at 10 points were more than 30-fold higher increased risk of death within 1 year. Now, I was at a talk in the Hansa in the Netherlands earlier this week, and one of the students had a great question. She said, you're doing all of this stuff and you're changing how we're looking at nutrition and cancer, but what is the next exciting area that you see in nutrition and cancer? And I said, what I think is probably the most exciting opportunity, particularly for the patients and for nutrition, is now that we're doing personalized medicine, we're doing targeted therapy, we're not going to have so much toxicity, and we may actually be able to show that nutrition intervention actually makes a difference in things like this in terms of how many people survive. And unfortunately, if we don't address it, how many people may die of malnutrition rather than of their underlying disease or the toxicity. So these are goals that I think we really need to all think about. Now, this is a patient who I had a number of years ago when I was medical director of a cancer recovery center. And when I first met her, she was 50 years old. She'd had a history of pancreatic cancer, and she'd had a Whipple procedure, which is taking out part of the pancreas and putting back together. And when I first met her, she was about 163 centimeters and 38 kilograms. Now, when I met her, I was going to examine her, kind of like we have an exam table over here, and I was talking to her and listening to her, and I said, well, I'm going to have you get up on the table, but I hear your stomach grumbling and rumbling and everything else. So I said, do you need to use the restroom before we go put you through the exam? She says, oh, no, Dr. Ottery. I just can't keep weight on. You know, I move my bowels at least 15 times a day, and I keep it in as long as I can so I can get as much of the nutrition as I can. I said, go to the bathroom. When it gets that far down, you're getting no nutrition. So I said, well, have an anatomy lesson when you come back. So she went to the restroom, she came back, and I said, okay, you have